You know how pleased I am to be here. I hope you could tell yesterday from my interaction with you, and I'd like to spend a little more time with you discussing restoration of the endodontically treated tooth. Now, yesterday we discussed some things about the definition of endodontics, and we know that the definition of endodontics is now a different definition is what? Prevention and or treatment of apical periodontitis. And we're interested in that because of the bacteria. If we can remove bacteria, then we have a better chance of having healing to occur. We also discussed whether it is prudent to perform root canal treatment in one appointment or multiple appointments. And then we discussed a particularly difficult diagnostic dilemma called the cracked tooth. And I gave it a special name in that it's called the longitudinal. Is that the term that I used yesterday? Yeah, okay, all right. Longitudinal tooth fractures, fractures that occur over time. And we compared the Kray's line, the cuspal fracture, the cracked tooth, the split tooth, and the vertical root fracture, and showed how there were differences in all of those scenarios and how we might be able to utilize this classification scheme when talking with each other from country to country, for example. Now today, you may have noticed that I have talked with you more about conceptual ideas and biological rationales rather than just how to do this and how to do that. I hope that that came through loud and clear yesterday. And somewhat the same thing again today with the restoration. I'm not going to teach you step by step this morning what material you should use, when you should use what material, things of that nature, but I'm going to discuss some thought processes that are maybe outside your normal thinking. We also discussed the importance of the root canal versus the restoration through the Ray and Trope study et al., 1995. And what did that determine? Something that I hate to say, that I'm not as important as you, right? That the root canal is not as important as the final core restoration we're finding out. And this was just the kind of a kickoff study. There are many studies that have followed this that indeed have found that immediate placement of the restoration does have an impact on the success of root canal treatment. So many of our endodontic colleagues now are performing more and more the core restorative material. And I'll end my discussion today talking a little bit more about that aspect. I have a title here, Why the Last Option First? And the reason for this title is that a few years ago I was on a panel of an endodontist, a prosthodontist, an implant person, and we were discussing the pros and cons of implant procedures. And it has come to my attention clinically in the United States that there are a lot of teeth that are being lost, a lot of good teeth actually, being lost to extraction so that an implant can be placed. And so I wanted to spend just a few minutes to discuss this general idea and say why the last option first. Why are you going to place an implant when you can very easily, in many instances, perform root canal treatment? We know from yesterday that the success for root canal treatment in cases with a vital pulp is what? What did we learn? About 95%. And if there's apical periodontitis, it goes down to 80%. We know that throughout the country, through different studies, it can be 50%. And then I ended up telling you that if you use a certain protocol of disinfection, we can bring that back up to the 90% level even for the necrotic cases with apical periodontitis. And so our success rate is actually very, very good in endodontics. if you consider making sure that we have the rubber dam, appropriate asepsis, and disinfection. Now, what about implants? Implants performed correctly also yield a high success rate. At least that's what they want you to believe. And why do I say that? What you believe. Many of you in dental school are in dental school right now, and you may not have the capability or the knowledge just yet to read what's in the literature to make decisions for yourselves. So right now you're probably being told more what to do than just why we do it in a lot of the dental schools across the country, because we just don't have time in our curriculum to do so most of the time. But what I would like to impress upon you is the importance to absolutely read the literature, not just go by even what your faculty, what I'm saying here to you today, what your faculty are saying, and especially the vendors that come to sell you a particular product, what they have to say, without looking at the literature as much as possible to make sound decisions for yourself. Now, the reason I am skeptical about saying high success rate for implants, even though I've written it down, is that actually there are not very many studies at all that show a high success rate for implant therapy. Well, if you actually look at the literature, for the most part, 98% of the literature shows us that we are not looking at success, but rather looking at survival when it comes to implants. Now, is there a difference between success and survival, do you think? Are those are words that are comfortable with you, right? Success, okay, I'm seeing some nod. Success is determined for root canal treatment. How? We want the patient to not have any disease, and we know that by looking on the radiograph to see if there's an apical radiolucency or not, or that the apical radiolucency was there previously, has decreased or disappeared. And we also want to make sure that we don't have any symptoms with respect to pain, right? And we can measure those things, and actually we measure those things significantly, almost to our detriment, because our criteria for success is very, very stringent. What do I mean by that? Let's say root canal treatment was performed on a tooth, and that root canal treatment was performed several years ago, and the patient is happy with their root canal. It is pleasing aesthetically, it doesn't hurt, they can function with that tooth. Everything seems to be fine as far as the patient is concerned. However, if a few years later there is still an apical radiolucency associated with that tooth, it is classified as a what? Failure in terms of root canal treatment. Okay? Now, on the other hand, what would the survival of that tooth be in the mouth? In other words, survival means, is the tooth still present in the mouth? Doesn't have anything to do with the sensitivities, the pain, the disease that may be present. It's just, is it present in the mouth? So that's the difference between survival and success. And I'm here to challenge you that when you read the literature yourself, you will actually see that we're not looking at a high success rate for implants. We're actually looking at a high survival rate. Now that's important because you may be advised, or you may come up with the thought process that, wow, implant placement has a 97% success rate from all the studies. And root canal treatment has a 95% or an 80% or somewhere in between. And so therefore, the two procedures, one has a better success rate than the other, we should choose the implant. That is one thought process that I absolutely abhor. I do not like that thought process at all. It doesn't make sense to me. Because what's more important for me is a situation in which we look at whether the periodontal ligament space is intact or not, the PDL. And this is what determines whether a tooth should be extracted or not. The American Association of Endodontists is right now one of the only specialties that is really interested in retaining a patient's natural teeth. Other specialties don't have that as their principal thought process, like in endodontics, saving the patient's natural tooth. Now, implants have come a long way. As a matter of fact, I'm extremely thankful that we have implants because it provides our patients with another treatment alternative if, for example, root canal treatment is not able to be performed. So I'm very, very happy that we have the implants, and I don't think it should be a discussion or argument or controversy. It's just that we have to review that we're talking about different definitions for success success and survival. So the discussion should be whether or not the tooth is restorable, what our restoration success may be, and in providing treatment options after restoration failure. Whose job is it to determine restorability? The general dentist, right? I want you to know and understand that we in the field of endodontics are more than welcome to help you make that determination. So if there's a question about whether a tooth can be saved and whether a root canal treatment can be performed, please get an endodontic consultation as well as other consultations that are necessary in determining whether or not the tooth actually should be extracted or whether the tooth should be restored appropriately. There are many different guidelines that can be used for determining whether a tooth is restorable or not. And one of the problems is we don't have any guidelines. These are just some ideas that I came up with at a meeting in 2006 in Chicago when we discussed this endodontic implant scenario. And I'm not going to go through all of these, but just like yesterday, I gave you the website that you can go to get download the handouts for the lectures today, and so you can have this information available to you. But this is just to show that there are a lot of things that we need to think about in considering whether a tooth indeed is restorable or not. I mentioned the periodontal ligament space, and I think that that's important. If we have an intact periodontal ligament space and there's enough tooth structure, there is no reason why a tooth would need to be extracted. We talked about cracks in teeth, and cracks can, as I showed you in several instances, cause loss of bone around the tooth, and those are situations that are right now questionable in terms of whether or not they should indeed be saved or extracted. But for the regular tooth that even has apical periodontitis only, it's probably a better idea to try to save that patient's own tooth because of the intact periodontal ligament. Now, what does that allow us to? What does that allow the patient to be able to do? Chew normally. Have you heard about proprioceptive fibers that are present associated with the tooth? These fibers are present because there is an interaction between the tooth and the bone through the periodontal ligament fibers. And these fibers are very important in terms of our ability to chew, and they serve as a defense function. Have you ever tried to bite down on something real hard, or you bit down on something real hard and you didn't know it, and all of a sudden your mouth opens up? That's because of the proprioceptive fibers. It is a protective mechanism that you actually lose with implants. One of the significant aspects that is wonderful about implants is that we no longer have to worry about decay. So disease is over with regard to having sugar bugs using the bathroom. Okay? And that's a wonderful thing. However, we have found with placement of implants that a new disease has come about called peri-implantitis. And that's the synonymous situation of having periodontal disease with natural teeth. And so these are things that still must be considered. In addition to looking at the studies with respect to success, there are some other things that you should be aware of with the studies related to implants. And of course, you can see my suggestion is that they are both valid treatment alternatives. But another thing that must be considered is that there are exclusion properties, exclusions that the studies have with implants, such that you can't use patients that are smokers, for example. And if you did, what would happen? Success rate would go down. They're usually younger patients. These are procedures from a research standpoint that are performed by experts that actually do implants. And so that also brings the success or survival level up. So all these are things that have to be considered in comparison with the research done on success for root canal treatment, in which the parameters are much more stringent. So please just keep that in mind. Now, if you tell your patient that they need an implant, I hate you. No question about it. As a matter of fact, if you tell your patient that they need root canal treatment, I hate you. Fooled you, huh? I hate you still. Because what's missing in that equation? What's missing? In those scenarios, did I provide the patient with treatment alternatives and explain and answered all patients' questions related to the situation? No. You have just told the patient what they need and performed the treatment, and that's absolutely inappropriate. We need to make sure that we are providing the patient with all of the treatment alternatives that are viable. Okay? And then let the patient make that decision. Now, what's the patient usually going to do or say? Well, doc, you're the expert. You tell me what I'm supposed to do. And that's when you give them your honest opinion about what needs to occur, but only after they have been provided with the informed consent. All treatment alternatives must be provided for the patient. Now, as far as post and core and crowns are concerned, there are some basic components here that we're going to talk about. Retention of the restoration and protection of the remaining tooth structure are indeed the indications for placing a core or a foundation in the tooth. The failure of restorative procedures is a result of not having a retentive post that is placed into position. The post may be too short or too long. I particularly detest the short ones where it leaves space in the root canal itself. No ferrule effect. Are you aware of what a ferrule is? If you don't know, a ferrule is actually what helps conserve a tooth and prevent it from fracturing. And I'll discuss that in just a little bit later. A post that does not fill the prepared space and actually incorrect post design, all these relate to failures. And retention, the factors related to retention are the post design, the depth of embedment, the diameter, the surface characteristics, and what you're going to use to cement or lute the post into position. An interesting study by Rivera looked at, in a non-destructive manner, the ability of a tooth to withstand forces of pressure and to determine whether a tooth was susceptible to fracture. In this design, they used an Instron instrument on premolar teeth and placed forces without fracturing the teeth to determine the fracture resistance. In this particular study, what was found was that two methodologies were used. One, performing a Class 1 cavity preparation and measuring the fracture resistance, and it was found to decrease only slightly. The next step was to perform a Class 2 on one side, and there was a significant decrease. Then a second Class 2 led to a much greater decrease, and then an endodontic access preparation was performed, and there was no further decrease. The second methodology looked at a situation where the access preparation was performed, had very little decrease. Secondly, the endodontic access performed next instead of last, and still no decrease. Then the Class 1, significant decrease, and then the Class 2, and then a second Class 2 on the opposite side with decrease as well. So it was determined from this study, and then some that follow, and there's a little bit of controversy here, but for the most part, the marginal ridge integrity was determined to be one of the most important aspects for restoration. So now you're probably taught in your lectures in prosthodontics and operative dentistry that if you have, for example, a traumatic injury where root canal treatment is needed, you perform the endodontic access, instrument the canal space, fill the canal space, and then probably just place a composite or an amalgam, probably a composite if it's an anterior tooth, and nothing else. You don't have to place a post. You don't have to place a cuspally reinforced restoration at all in those situations. Now, is a post useful? Well, for the most part, there are many more disadvantages than there are advantages for post placement. Actually, as a matter of fact, there's only one real reason to place a post in a tooth, and that is simply to retain the restoration. Most other aspects of a post are actually end up being detrimental in terms of causing fractures by transferring the forces of mastication, weakening the tooth. You can actually fracture the tooth during the cementation, and also you can have perforation during the preparation of the post space, and it also weakens the amalcor foundation itself. So if at all possible, my suggestion to you is to not use a post. Only use a post when it is indeed absolutely necessary. There are different types of posts. There are threaded versus non-threaded, parallel versus tapered, and proprietary versus custom fit type of combs. And which one is better? Well, I don't have the answers here for you. Your prosthodontics faculty probably will, but just some general guidelines. If you have a situation in which there's a short post, you're probably going to need a more rigid a short tooth length. You're probably going to need more of a rigid post design. as opposed to a regularly established tooth that has a natural length of, for example, 21 millimeter length, then more than likely you can get away with having a more flexible post. There are also considerations of metal versus fiber posts. Have you heard of the fiber posts at all? Okay. The metal posts are cast metal, which are hard and rigid, and what we have found overall in looking at the literature is that when forces of mastication or other types of forces are generated through the post, what happens in those rigid metal posts is that the energy is transmitted to the tooth, and what happens? The tooth fractures. This is in contrast to what we generally see in the literature with the more flexible fiber post. What happens? The same type of force generated does not get exerted to the tooth structure, and so if anything breaks, it is the post itself. Now, which is worse? Having the tooth fracture or having the post fracture? Tooth fracture, except it's a pain in the old derriere that you have to go back and take out that post that fractured, but at least you have a tooth that's still present in order to perform that procedure. We also need to look at the amount, what endodontics is interested in, of course, is the amount of remaining root canal filling material at the apex. And from a prosthodontic standpoint, there are many more things we're interested in, like post length and width, the surface configuration, the cement, and the type of core that we're going to use. And of course, this is what we're trying to prevent, this fracture that may occur with too large a post, too rigid a post, with the appropriate force causing problems, especially with there being no ferrule to support distribution of those forces. So let's talk about this ferrule. Basically, the ferrule consists of a band of metal surrounding a root at the core tooth interface and extending 1 to 2 millimeters, depending on what you read in the literature, apical to that junction. So we have some tooth structure where we can get a band of metal on the tooth itself. And so this is a diagram of what we're talking about, a situation in which there is an amount of tooth structure present called the ferrule, which helps to support the tooth and prevent fracturing of the tooth. Many different people have talked about it. This is just one study by Gelfand. Nair et al. Have also compared amalgam cores with full crowns, cast cores with full crowns, and natural teeth, and their results indicated no difference in compressive strength when the crowns were constructed with a 2 millimeter ferrule. The authors advocated an amalgam coronal radicular core technique utilizing 2 to 4 millimeters into each canal, kind of what I was talking about yesterday with the intraorifice barrier, to aid with retention in the pulp chamber space. So to summarize, posts do not strengthen teeth. Posts do not strengthen teeth. Unfortunately, I wish that were not the case, but they don't. When you place the primary purpose of placing a post is to fasten a superstructure to the root. In other words, to retain the restoration. As far as endodontics is concerned, not much more. We want it to retain that restoration without causing undue stress on the tooth structure. And then, very important is the construction of a 1 to 2 millimeter ferrule that appears to be the most important factor in terms of the restorative equation. Having that ferrule is important. Now, there's not one standardized post design because of several reasons. First of all, the remaining coronal tooth structure, you may have an abundant amount or might not have enough. Also, the root morphology with curvatures and things of that nature, and the occlusal forces are different in different people. Some people, for example, are bruxers and have more forces of mastication. Some people are type 1 and go get them like me, where you they have a greater tendency to grind and cause more occlusal forces on the tooth. Basically, the post-space preparation itself consists of a two-step procedure. You're going to start off by removing the root canal filling material and then probably, hopefully, minimally enlarge that chamber. Now, I'm not sure what you're taught here with respect to removal of gutta percha, but I highly, absolutely highly recommend that at least your initial removal of gutta percha be done with heat. Caliente. Is that it? Heat. To make sure, indeed, that you're not going to perforate. If you use other instruments that are available, what are you using? Gates Glidden drills? I hate them. Especially because they can be misdirected and cause you to have a perforation. Have you ever heard of that term? Perforation? Burst lips disease? Say it real slow. Burst lips disease? Okay? I'm sorry, I had to say it. That's for Dr. Padilla. Burst lips disease. And so it is much better to start the preparation of removal of tooth structure with heat. It is extremely difficult for you to perforate a tooth using heat with a plugger. Or there are different specialized instruments like the touch and heat or System B units that we use for filling root canals, things of that nature. Anything that can apply heat is much better at preventing perforations from occurring. And then use your other instruments, your Gates Gliddens or your special drills for preparing the post more specifically. Now, how much gutta percha or Resolon do we need to leave in the canal space to ensure that we have a sealed canal in the apical area? There's a lot of different research, but pretty much it's between 3 and 5 millimeters. From an endodontic standpoint, of course, we want 5 millimeters because we want to make sure that that seal is maintained. And there are different research studies to show this and even more. Okay? So 3 to 5 millimeters at minimum. Now, the worst thing that you can do, in my opinion, is to remove root filling material and then not have the post go down to the material that's left in the canal space, thereby leaving a space or a gap in which bacteria can live and thrive and survive. Okay? Also, many times, the amount of post space necessary is sometimes rather minimal because all we're trying to do is to retain the restoration only. So sometimes there are other rules. There's the rule of thirds and the rule of halves and all these different things that you probably are going to be taught with regard to prosthodontics in terms of the length of placement of the post. And those are all good, supported by literature, but just make sure that you don't remove more root canal filling than necessary because these posts do not strengthen roots. They set up a scenario where more of them cause a tooth to fracture. Now, some of you, as far as restoration of the endodontically treated teeth, will have to perform restorations on teeth that have had root canal treatment in the anterior region. And some of these may even require a bleaching procedure called an internal walking bleach procedure in order to lighten the tooth. And this is a study from many years ago that was looked at, not really a study, more of an informational finding, to give an idea of how we might be able to perform these restorations. Now, keep in mind that there are dental tubules that have a S-shaped configuration at the level of the junction of this cement, the cementum and the enamel, the CEJ area particularly. And you may have been taught that we want to remove the root canal filling material to below the level of the CEJ. Is that what you're taught in endodontics? Okay? I absolutely disagree with that thought process. Wouldn't you know it? Okay? Now let me tell you why. And I'll tell you why we're both correct. Have you ever seen anyone, okay, the reason that we're removing the gutta percha and sealer to that level is because what? Sealers stain. Have you learned that? Okay, sealers stain. So we want for that staining not to show. Now, have you ever seen anyone in your practices in dental school with gingival recession? Yeah? Okay. What happened? If this was an anterior tooth where the patient has a very high smile line and they have gingival recession, I can tell you which ones have had root canal by looking at the dentin because of the staining. So therefore, what we really want to do is to remove that level of gutta percha or Resilon down to the level of the gingival margin so that it is not seen, rather than just concentrating on it being below the cemento-enamel junction. Now, 98% of the time, the gingiva is where? At the level of the cemento-enamel junction. So most of the time, you're going to be correct if you remove the level of gutta percha below the level of the CEJ. But I want you to throw that out of your mind and think more about the level of the gingiva rather than the position of the CEJ for that reason. Now, unfortunately, when this went to print, they placed a yellow area in here. That was a mistake, so please ignore that. What we're trying to do is to place a barrier material, and then the chamber is here empty, so that, for example, if you were bleaching, you would use a solution of sodium perborate. Is that what you're taught? Sodium perborate? Are you taught to use hydrogen peroxide in combination with the sodium perborate? Okay. Here again, I absolutely do not like that procedure because it has been shown in the literature that a certain small percentage of individuals get cervical resorption when hydrogen peroxide is used with sodium perborate. So the solution is, and my suggestion, supported by research evidence, is to just use the sodium perborate with water or saline or an anesthetic solution alone first and see if there is an acceptable result that is able to be obtained. If not, then you have a discussion with the patient, informing them that, well, I have another material that we can use, but in a certain percentage of cases, we get what is called cervical resorption. We can try it depending on how severe you would like to have the tooth bleached and see if that will work for us. A third type of situation exists, and that is related to heat. Have you been taught to use heat along with hydrogen peroxide and sodium perborate? I hope not, because the incidence of cervical resorption in those cases is extremely high, occurs more often than not, and so that's why we don't advocate heat. So I would suggest not using the hydrogen peroxide, if at all possible, and just using the sodium perborate to perform the bleaching procedure. And that we make sure we have this barrier material here. The barrier could be most anything, IRM barrier or glass ionomer barrier or flowable composite now, for example, could serve as good barriers because the oxidation reaction that occurs with the sodium perborate can be significant, and we don't want that to go through the root canal filling material and reach the apical portion of the tooth. Another significant consideration is that bleaching works what percentage of the time? Have you heard the expression in the United States, 50-50? 50-50? 50% of the time, bleaching has to be redone again, unfortunately. I wish it weren't the case. Maybe we need a different material or technique. But you're going to have to sometimes go back in and redo the bleaching procedure. Also, root canal treatment itself is what percent of the time? 90-some% of the time successful, but 10% of the time you might have to go back in and perform a retreatment procedure. Now, in both of those situations, a retreatment or a rebleaching, you're going to have to remove that core restoration material. Suppose you have used, as you're probably taught most often, composite material to fill the chamber space. And suppose that composite matches beautifully with the dentin, as it's supposed to. When you go back to remove that material, there is a high likelihood of possibility of perforating, more likely out the facial surface when you go back in to remove that restorative material. And it's hard to distinguish many times with our advancement in composite polymerization. It's hard to distinguish sometimes between the restoration and the composite. So in order to prevent this situation, what I would recommend is that we place a material here that is light in color, that is significantly different from the color of dentin, so that when we remove the remaining composite material, we will be able to see on the facial surface where that material actually is. There are different types of materials. I used to, in this article, the idea back in '97 was to use a white-colored gutta percha. The disadvantage now, and please criticize this article significantly, the disadvantage of having the white gutta percha is that it has no sealing property whatsoever. You have already been taught that gutta percha placed in the canal space does absolutely nothing to seal the canal. It's the sealer that seals. So the gutta percha is used only to place the sealer to position and hopefully fill up the space so that we don't have to use a whole lot of sealer. Because what happens if we use a whole lot of sealer? We get shrinkage, right? The shrinkage properties occur, and when we get the shrinkage, then that creates spaces, and I've already told you, I hate spaces inside root canals. Okay? So a better material here, and one that's suggested in the article, is a glass ionomer, and now we have the nice flowable composites that are opaque that can be used, and that's what I'm using now in these situations, right along the facial surface only in this portion, and then the remainder, of course, can be filled with the composite material. This just shows on a radiograph the level that we need to be in order to be 2 millimeters below the level of the CEJ on the radiograph in removing the root canal filling material. This is what the dental stopping material looks like. We can heat it up, place it into the canal space. Preferably now is the flowable type products. I don't care which one necessarily. The one that I use is by Pentron called Flow-It, and it has an opaque shade. And this is the same material that we can use for the intraorifice barrier in teeth that have an aesthetic concern. So in posterior teeth, we use a different material that is purple, And for the anterior teeth with aesthetics, we use the, not the clear here, I'm sorry, not the clear, but the opaque material. For the gutta percha, you can heat that up, heat the gutta percha and place it into the canal space, then place your acid, primer, bond, and composite in the canal space. Another thing that I would like to discuss with you more, we talked about it yesterday, but I feel that I want to provide you with a little more detail, is whether or not we need to place an intraorifice barrier. We have a sign in our endodontic clinic that says asepsis is everything. Asepsis is everything. Big sign. Asepsis is everything. When you walk in, that's the first thing you see in our clinic. Asepsis is everything. The seal is the deal. Everything eventually leaks. And so our thought process here, as I mentioned before, is to go ahead and place the core material immediately after completion of root canal treatment. Sometimes that may not be necessary, that may not be possible. It is necessary, but may not be possible. And in those conditions, we actually are teaching our students to place intraorifice barriers. They are affectionately known as plugs. Plugs, like you plug up something. This is an example of a case in which root canal treatment was initiated and completed. And unfortunately, there's a problem with the periapical radiolucency present on the distal root. And we have incomplete filling of the root canal space, and they were not able to locate the second mesial canal that's present. I made an angled radiograph preoperatively to see what the case looked like and to make my own determinations. And we performed the root canal treatment procedure. You can see that we gained length on the mesial aspect and actually located a second canal in the distal. How often does that occur? 2 canals in the mandibular molar, distal root. Do you know? About 25% of the time, 1/4 of the time. Wow. Woo, amazing. And root canal treatment was completed, and I made an angled radiograph. And then, look what happened. Oh my goodness gracious. I can't stand it. What has happened here? You know I hate spaces, right? That's a space I hate. Why remove my material if you're not going to utilize that space? Also, look at the size of the post in the distal. I already told you there are 2 canals, separate canals, and you got a real big post in one of them, close to becoming a perforation, possibly, since there are 2 canals, which indicates that there is probably a kidney bean or figure 8 configuration of the root itself. And this eventually failed. Even though we have tremendous healing of the root canal space, this failed due to fracture of the distal root. Okay? So please only use the size of post necessary and make sure that you utilize the post space that you create. What I'm trying to show here is the difference between being flush with the orifice level versus being below the orifice level. And the question that I had is an amalgam plug needed or not? Is that going to gain us any additional retentive capabilities of the restoration? And so looking back in the literature, and especially in situations here, in this situation, it probably doesn't make as much difference since we have intact tooth structure, 360 degrees, as it does in a situation like this, where there might be additional retention gained by placing that amal core a little deeper into the canal space. You can see how if you pressed on this restoration, it might move. Whereas if you press on this restoration, there would be a little more resistance to that lateral movement. And a study by Nair, that same study I mentioned before, and also Ulusoy, with respect to the depth of amalgam in the canal space, it's speculated that it's not necessary to use amalgam as a coronal radicular core material if adequate volume of chamber exists. If minimal chamber volume exists, you may gain an additional retention and seal. So most of the time you don't need it, but sometimes you will. We've already talked about the Ray and Trope study already, but that's to remind us that we maybe should consider placing a core. In situations in which you may not be able to place the core, this shows root canal treatment on a tooth, mandibular second molar, with a big overhang here that's present, angle radiograph. This is our working length, and our trial pack radiograph, and our fill. And you can see in the fill that there actually is not a lot of space present on the mesial and a lot of space present on the distal. Well, what has happened? Let's take a look. We are using a material called Resilon, which is more composite-like than gutta percha, but the idea is that you're going to end up filling the case, removing the excess root canal filling material by searing off the material with heat, and you're left with this sealer that is in the chamber space. I have found that one of the best things to use to remove that excess sealer is a chlorhexidine pellet to clean away the excess. You could use water, you can use alcohol, all these are good. In this case, it was Luxacor. We're now using a flowable composite instead of a packable composite. Luxacor is a packable composite because I have found that we get many more voids with the packable than we do with the flowable. There are still some voids that occur with the flowable, but much less. And so we're using a material called Permaflow, purple shade now, but the idea here is that we're placing it only in the mesial, not in the distal, because we're suspicious that there may be need for a post to be placed in that distal aspect of the canal space. So therefore, we're going to leave this material out if there is an indication for a post. Why? As you can very well imagine, these are difficult to remove without removing excessive tooth structure or perforating the canal space. This flowable composite may provide added protection against bacterial contamination, especially if the temporary is lost or leaks for some reason, or if the restorative procedures are not performed under rubber dam isolation. Does that ever happen here? Do you use a rubber dam when placing restorations? Always? There's not a time when saliva hits the tooth when you place a restoration? That's awesome, if that's the case. Very unusual in the United States. Now, this is not a situation, please don't get me wrong. Look very carefully. You see the blue here? The blue indicates the placement of the flowable composite. We are intentionally not trying to place this flowable composite all over the floor of the chamber. Intentionally not. We want it to look just like this. And even more so, very critically, we don't want to use flowable composite to fill up the entire chamber. Why? Flowable composite does not have, it's flowable because it doesn't have fillers that are present. And the fillers give the composite more strength and rigidity. And with that comes a resistance to, an ability to resist occlusal forces. So Materials like flowable composite and glass ionomer restorations are actually very poor core material restorations. It would be much better to use composite or amalgam or materials of that nature in the canal space as a core material. So the disadvantages of placing the intraorifice barrier are that indeed that it is difficult to place and it's difficult to remove. So these barriers should be considered. We have some literature to support this idea. This is just another case in which root canal treatment is initiated. There's an apical radiolucency. The diagnosis was a necrotic pulp, chronic apical periodontitis. The working length is shown. This is what it looks like upon with the excess sealer and that excess sealer removed, and the placement of an intraorifice barrier and an IRM, cotton pellet IRM. And this is, we can see the root canal filling material. We can see the placement of the intraorifice barrier and the cotton pellet and IRM sent back to the restorative dentist. This may be a compromise in those situations where you're speaking as an endodontist with the general dentist, and the general dentist for some reason says, I want my $200, I don't care about the patient. And so therefore, you can still try to protect your root canal filling in such a manner. For your own selves, when you perform the root canal, you don't have that argument. You're going to place the root canal, then you're going to get paid for placing the core material, and you're going to get paid for placing the crown if necessary for the tooth. I might add that this is so important for us at UNC that we are placing, even though it takes more time and it's tedious and very difficult, we are absolutely not charging anything for the placement of these intra-orifice barriers. We believe in them so much that they are helping us with our root canal treatment that we have elected to not have any charges whatsoever for this material. Now, UNC, a study was performed to look at whether or not intraorifice barrier placement would be a good thing to do. And this is a histologic study that was done on animal model. And we evaluated the apical inflammation. This is a study by Dr. Shizuka Yamauchi et al. We looked at whether there was going to be no inflammation, a mild amount of inflammation, or a severe amount of inflammation after placement of the root canal filling and leaving that root canal filling open to the environment in a carious diet. So what we have here is root canal treatment was performed. Without a plug, what we found was what? 89% of the specimens had mild or severe pathosis histologically with just root canal being placed. More significant to me than the 89% is the high number of severes, or at least an intermediate number of severe inflammation that was present. Now, when a situation occurred where the root canal filling was removed and a core material placed only as an intraorifice barrier with either IRM or composite, look at the numbers from this study. Significantly decreased. I still don't like 38%, but another interesting fact is that with the numbers that were present, very few of them were severe reactions. Okay? So this is what it's like with IRM and composite. Almost probably doesn't matter what you put in there as long as it's a sealing material. Some of you might ask, why don't you just fill the entire chamber up with gutta percha? Have you ever thought about that? Why do we go through so much trouble searing the gutta percha? because it is actually an extremely terrible material for sealing. We use it in the canal space because it's protected and it can seal very nicely. But if you expose gutta percha to the oral environment, as a matter of fact, that's what is used as the negative control in studies. That indeed, we do get bacterial communication through the root canal space. So, flowable composite is not placed in canals where a post or plug is needed so that we can make that post space preparation. I've already stated I would suggest that you create, at least initially, the post space with a heated plugger. Don't let it cool. If you do, you have the potential to let that stay in the canal space and it cools down, and then you might pull out the entire root canal filling material. Okay? So you get it hot, put it in very quickly, remove only 1 millimeter of material at a time, go back in consistently, remove it back and forth, heated instrument all the time, don't let it cool down. And then you certainly can use rotary instruments very carefully at that point, but now you already know the path that you need to place those rotary instruments in order to further prepare your canal space. And of course, we as endodontists are always readily available. Just contact us. We'll do the post space for you, at least the initial part. We're service people as endodontists, as you probably have already guessed. We're the ones to get rid of the patient out of pain and do the post space for you, and we try to do everything for you. Now, in that trying to please the referring dentist, you might see a specific, an ongoing theme here. What is it? Communication, communication. Biological principles is what we've been talking about mainly in these lectures. And then there's another thing called asepsis here. Placement of the coronal restoration after completion of the root canal fill is variable, but based on mainly on asepsis. And there is literature support. This is just another case in which root canal treatment is performed. A little extrusion of sealer here, and you can see the intraorifice barrier placement in position and recall. So please read that chart or referral letter that we send back to you so that you know what material was used, whether a restoration was placed or not, and whether there's a cotton pellet in the canal space. That's one of the worst things I've seen is cotton pellets still present in the chamber spaces after the tooth has received a crown. And also look at the postoperative radiograph to look at the level of the root canal fill, look at the space, quote unquote, between the root canal filling and the restoration. Awesome. How we do? Fantastic.